Hey, welcome to episode number 27 of the Go-To Physio Podcast. In today's episode, we talk all about the importance of the upper rib cage and the occiput to cervical spine health. I hope you enjoy the show. Hey, welcome to episode number 27 of the Go-To Physio Podcast. My name is Dave O'Sullivan, and another week down in the Go-To Therapist Mentorship. And in this episode, I want to talk about some key lessons and I suppose topics that therapists learned in Module 5, which is all about the cervical spine. And in the mentorship, just like last week's episode where we talked about when we look at lumbar spine patients, we put a big emphasis on ribcage mobility, what's happening at the pelvic floor, what's happening at the diaphragm, what's happening at the abdominals, the transverse abdominals, because they're all interlinked. And we take this approach, and we also use it for the cervical spine. And clinically, I found this approach to be very, very effective if we follow a systematic process. And how we continue this approach up the chain is if we look at a cervical spine patient and let's say, for instance, a lower cervical nerve root or a disc issue that a lot of us would come up against, we would still ask the question, what's not doing its job, okay? Or why is this area of the body sensitized? Or why is this part of the body maybe tolerating a little bit more load than it would like, and hence potentially giving it, a conscious, the person a conscious experience or conscious sensation that something maybe isn't quite right and they need to take action. So we start Module 5 by talking about the importance of the upper limb, and specifically what we covered in Module 3, which is force transmissions from the fingertip all the way up to the shoulder. We continue that journey in Module 5. And again, if there's a poor force transmission maybe through the upper limb, if the upper limb's not working as one, then very often what we may see is somebody as they're going to lift something, that we might lose a co-contraction at the elbow. And then the other thing that might couple with that is more than likely an elevation of the scapula. The upper trapezius may tend to help out, etc. And again, if we look at these tissues and where they attach, the trapezius, again, it's attaching to that to the cervical spine, okay, and obviously thoracic as well, but the middle fibers. But the point here is, again, what's not doing its job, the 80%, that's maybe causing the 20% of the attention that we'd focus on, which will be obviously the traps. Because again, if we felt that the traps are contributing to this pain experience, we might get some short-term relief with a bit of massage or dry needling or hands-on treatment, whatever you want to do, even manual therapy at the cervical spine. But the next time that person goes to pick their child up or pick their rucksack up or pick the shopping up, again, what's maybe contributing to put an excessive load along that cervical spine. The other big thing that we want to talk about there also is the importance of the rib cage. Okay, so again, we talked about the lower rib cage in particular and the ability of the rib cage to depress, retract, and the ribs to internally rotate, again to help the obliques, but also to get some movement through that mid back thoracic spine, so that we don't access the lumbar spine maybe too quickly in the movement or too early. So the same thing again would happen with the upper rib cage. Now, the upper rib cage, there's obviously not as much movement through that upper rib cage, but what we're particularly interested in here is the reactions that happen when maybe we go to reach. So again, if I'm going to reach, if I'm sat here on a chair and I reach my right hand on its own forward, essentially I'm getting relative right cervical rotation there, because my body's going to go round, or my torso is moving under my neck, so to speak. So if you hold that position and then you move it to the you keep that position stuck, and then you bring your hand back to the original position, okay, then you're going to see that you're actually looking over your right shoulder, essentially. Hopefully that makes sense on a podcast. But so the point here is we need to be able to reach, we need to be able to, when we reach, we want to be able to protract the scapula. We want that rib cage to be able to depress, retract. Okay, so again, those ribs, especially the upper ribs, they need to be able to mobilize. Iliocostalis again is another big tissue there, and then a big tissue that we focus a lot on is the serratus posterior. And again, that's a very important muscle, in my opinion, when we look again at where it attaches. And we can see that it attaches, on the spinous process from C7, into the upper first few transverse the spinous processes. But most importantly, then it blends into that ligamentum nuchae essentially. Okay, and again, that ligament, it's going to transmit forces. Okay, again, it's going to maybe go up, down, over the those forces could go over the higher cervical spine or higher cervical spine tissues. Okay, so again, we look at that. We look every time we need to look right. Those spinous process need to be able to mobilize. Okay, and then most importantly, we can see, well, not most importantly, but very importantly also, we can see that the serratus posterior attaches down into the ribs. I think it's about 2 to 5. It is. Okay, so again, we've got a muscle here that's, essentially, in my opinion, it's a big force transmitter for when we lift somebody up or we lift something up, or we take an external load, we transmit that force to the rib cage. I think that's a big muscle. Any muscles that attach from the ribs to the spine, I'm thinking a lot of these muscles, when they work under isometric conditions, are transmitting a lot of force as well throughout the body. Okay, so again, when I go to reach, and I want, I got to reach down, okay, and I depress my rib cage on one side, those ribs are going to have to mobilize, okay, and if I reach down and look over my right shoulder, those ribs and that spinous process are going to have to mobilize. We want that serratus posterior to be able to lengthen, but we also want it, as I said, to work in under isometric conditions. So again, we in module 5 we look a lot at some simple tests to see, is that rib cage mobilizing with the cervical spine? Is it mobilizing by itself? And are they both working well together under isometric conditions, but also when these tissues need to lengthen? So that's another big one. And then the last piece of the puzzle, okay, that I want to talk about today, and
hey, I hope you're enjoying today's show. For more clinical content and tips to help you implement this content in the real world, please visit go2physio.com for more information, including my 6-step patient adherence checklist, which you can download for free. And also there's more blog content that helps you implement this stuff in the real world. You'll also find links to my YouTube show, the Go-To Physio Show, as well as lots of more information to help you become the go-to therapist, helping real patients get real results in the real world.
It's not the last piece of the puzzle, but the last bit that I want to talk about today is the upper cervical, okay, and specifically the occiput and the ability of the head to move well on the cervical spine. So again, when we go to look down or we go into neck flexion, a lot of the movement at the start is happening on the head over the cervical spine, okay, or head on neck. So just like when we go to touch our toes, we want, if we can get a bit of ribcage depression retraction, we're not going to access our lumbar spine too quickly. If we have good movement or good lengthening even of the occiput, occipital muscles, if we can get that head moving well over the neck, then again, we're not accessing that cervical spine too quickly. Okay, so again, with a lot of disky type patients, when they bring their chin to their chest, you'll see again, that'll radiate some symptoms. Whereas, one of the tests that I teach on module 5 is an ability to lengthen the occipitals. And very often when we do that test, that's going to reproduce the symptoms anyway. And we're not actually getting cervical or much cervical flexion in that test, yet we're able to reproduce the person's symptoms. Again, we desensitize these tissues, restore the ability to lengthen, and very often we'll increase their cervical flexion very, very quickly. Now, if it's a sensitized, quite acute sensitized patient, then they'll still probably feel that at end of range, but the time it takes or the range it takes before the symptoms come on, will dramatically improve even on, on that first session. And then it's just a case of the other contributing factors and non-physical as well. Breathing, we talk a lot about that in Module 5, because again, if we've got an increased respiratory drive, if our breathing is kind of pattern, so to speak, off a little bit, where we're using a lot of accessory muscles, the scalenes, they attach down to the ribs, they attach onto that transverse process. Again, very, very important. SCM, and obviously we've talked about the traps, whereas, there's some studies showing that when we can nasal breathe, we can slow our breathing down, we can make it lighter. It dramatically changes the EMG of all these muscles. So again, there'll be the physical contributors, the non-physical contributors, and it's putting it all together. And again, that all starts at Module 1 in the subjective assessment. Okay, so there's quite a bit there that I've talked about today. So again, please don't just take this information and go, okay, that's all I need to do. It's not. The beauty of the mentorship is we've been building into this. Okay, so therapists are going to be using Module 1 to even some of the movements in Module 2, which we look at whole body movements. Okay, so again, the ability to reach that right hand down the right leg, what's happening to the rest of the body. We still want to see what's happening there and the impact that has on the cervical spine. So we'll use some of the Module 2 assessments, which will be predominantly lower limb. We'd use Module 3's upper limb stuff. We'd use Module 4 again, looking at the rib cage, looking at the pelvis, mobility, the ability to tolerate load well through the abdominals. That's going to be very important, because again, we might want to help the diaphragm do a little bit more work to take load off the accessory muscles. And then obviously we use Module 5 stuff then essentially as kind of the icing on the cake. And obviously we still want to be looking at the 20% as well and desensitizing symptoms. Okay, so that's it for this week. I hope that was useful. Next week is an implementation week for the therapists, and they kind of cover some business content, which I'll chat a little bit about. And they also, I've just posted in a Facebook group this week. I'd like them to really focus on the effective explanation this week and get really good at communication skills. So again, using this implementation week to catch up on the content, but also get even sharper at communication skills. As always, head over to www.thegotofysio.com/blog. And I said we've got lots of content and resources there for you as well. And obviously you can pick up my book at www.thegotofysio.com. And there's, as I said, there's plenty of information about our courses, our books, and obviously the mentorship itself. Okay, have a great week, and I'll speak to you soon.